Karelee Close is from BCG. Rabbie is from Boston Scientific, and Tom Breeze is from Baldwin Health. So please join me in welcoming them to the panel. What I've asked them to do is basically just do a roundtable, introduce themselves, take a couple of minutes, maybe starting with Peter, and emphasize in their own background and responsibilities.
I'm Peter Mountney from Siemens Healthcare. I'm a senior key expert scientist, but I run programs of research across the technology readiness spectrum. So very highly innovative projects. We're exploring totally new applications, right through to things where we're taking prototypes to clinical studies. But the overall goal is to translate cutting-edge technology into products and prototypes that can affect patients, so deliver a better patient experience or better patient outcome that can affect the hospital or the providers or the doctors to allow them to deliver a better experience and to deliver value to the hospitals to reduce the cost of healthcare, but providing increased quality of healthcare as well. So a little bit of touching on the idea of value there. So it is very, very difficult and challenging to bring ideas from the initial concept through to something that's delivering value. And I think we touched a little bit upon it at the beginning in the previous session, where we talked about how you actually need to be very dynamic and you need to change. You need to respond to what's going on in the hospital, your customers, your end users. And the way we tend to address that, and one of the most effective ways we've seen to going from idea to really delivering value, is to work very, very closely with partner organizations. You can't do this on your own. So we like to work with hospitals very, very closely. We like to work with academic institutes very, very closely. And by very closely, I mean putting a team of all these people into one room and really focusing on one particular goal. And you really see the idea totally evolve and change if you're able to produce that kind of situation.
Yeah, Karelee, because what it means for you specifically in your background, going from idea to value.
Sure. So my journey with digital health started at the beginning of my career. In fact, I guess when I was like a teenager, and my grandmother died of something in a hospital when it shouldn't have happened. And I think that ended up sort of creating a little chip in the back of my head that said we could do this stuff differently. It was about the same time that we were getting quite a bit of advancement in technology. It was called, e-health at the time. We still call some of it e-health. And I did an informatics degree, so health informatics. I spent 10 years in a teaching hospital in Canada, if you're trying to place the accent. And there I did work on utilization management, using data to transform clinical processes and activities. And I understood the change management challenge there when we were starting to put PCs in nursing stations. And one of the nurses in the critical care unit, I was trying to show her what to do, and she took the mouse and put it on the floor and started using it like a sewing machine pedal. And I thought, uh-oh. I mean, the world had been using PCs for a long time, but this particular lady hadn't. So that was when I started understanding that there was a bit of a change management challenge. I joined BCG after an event like this, actually, where I saw that they were developing an e-commerce practice and really using technology to change businesses. And that I've been at BCG for longer than I'd like to admit. You'll start to work out how old I am. And I lead globally our digital health practice, which covers biopharma, medtech, and payers and providers. And I also lead our technology practice in Western Europe and South America. Where's the value? I think I did a TED Talk a couple years ago, and the title was, "Will Digital Disrupt Healthcare or Will We Die Waiting?" Because I'm actually quite tired of talking about there is all this stuff that we could do, and I feel like the technology's there, the data's there, mostly, lots to do with that, It's really, and the value's there, and the need is there because we have shortages of cash, shortages of doctors and nurses, and an aging population, as we heard from the keynote speech. The value's there, but we have trouble adopting it. So will we die waiting is my sentiment around the pace of change. I do think it's an exciting time right now in terms of the level of investment. It's unprecedented. So the market size is about 175 billion in terms of digital health worldwide. There's about 30% of waste in most healthcare systems, our best estimates. That waste can be addressed by data and technology. So where's the value? I think it's fundamental. It's fundamental to people like my grandma, who shouldn't have had something happen and it was a quality issue. We should understand quality much better, but it's also fundamental in terms of our societies, right? The healthcare spend and the way that we do this stuff is completely backwards, right? So if we talk about AI and doctors not being able to use AI or people not being comfortable with AI, we use it already with pilots in planes. And I'm on a plane a lot, and it doesn't replace the pilot, but it's something that we accept a lot. It's something that we accept in consumer products. It's something that we accept in other industries. I would argue that it's something that we should and could have happening in healthcare.
Thank you. Welcome. Rabbie, could you tell us about your background with Boston Scientific and tell us what this concept means for you?
Sure. So I'm Rabbie. I'm Senior Manager with the Healthcare Solutions and Partnerships team at Boston Scientific in Europe. I joined about 3.5 years ago from BCG, in fact. And
Good foundation.
Yes, indeed. And together, in fact, with...
Now you've got a real job.
Now I don't just come up with ideas, I actually also implement them. No, but I think my team is composed, in fact, of a lot of people with mixed backgrounds, including consulting, because Boston Scientific realized about 3 or 4 years ago the importance of really going beyond the device and bringing value-based healthcare in the way that it can do best to this changing ecosystem. So at the time, we were a startup unit almost inside a corporate, which has its pros and cons, I would say. Mainly pros because we didn't have a cash flow issue, but we did have to justify our own existence at the end of each year. And I'm pleased to say now we're a fully fledged division, announced on Wall Street through the JP Morgan conference that Advantix, which is our brand, is something that Boston Scientific does. Advantix is basically a suite of healthcare solutions delivered either through our own people, consulting services almost, solving problems for providers and systems. It can be delivered through partners. We've built a number of innovative partnerships with third parties that have either technologies or capabilities that we leverage. And increasingly also using digital tools that we either build or buy. So I think the sorts of problems that we're addressing are anything from financing support, operational and growth needs that hospitals have, and even just cost reductions and outsourcing that can sometimes be a basic requirement. I think for me, the important thing to recognize about value is that it's very much in the eye. It depends on who you're talking to. It's in the eye of the beholder. And while I learned in good places like BCG the theory behind value-based healthcare, which is absolutely right, outcome has to improve, cost has to be down, numerator, denominator, that's what makes value. The reality is it depends how you measure outcome, it depends how you recognize cost. And our systems are not well set up neither to recognize or to measure good outcomes. And there's a lot of work happening around that, I know, but especially not to recognize the total cost. And the NHS, with a quite siloed-based system around cost, is increasingly challenged by that, even though the ROI of some of these solutions could be quite obvious, and the value could be staring you in the face. If it isn't recognized, it isn't value. So I would encourage you to think about value as who are you speaking to and what does value mean to them. If it's a clinician, value can be very much in terms of efficacy, in terms of efficiency of their time, in terms of the ability to do more of what they want to do. If you're talking to finance director, it's all about the dollars and cents. But if you're talking to others, users of systems could be nurses or operational people. Again, making user interface better can be very valuable. And then, of course, you've got all the patient-centric activities, either B2C, digital health, or even activities that hospitals are doing that are more B2C. Value for patients could be very different. So I think it's very much and that sort of thinking about value then drives how you go to market, what you do to discuss your proposition at every stage in the game, and everything beyond that. So it's a complicated area of value, and I guess that's why we're talking about it in this panel.
Yes. Tom, can I ask you to talk about your work at Babylon Health and what value means for you?
Sure, happy to do so. So I'm Tom Breeze from Babylon, as mentioned. I was a non-clinician by background, and then worked as a consultant for a while. So if you think of me as a less experienced version of Karelee and Gil and a less clinically credible version of Vishal, that's the sort of space for this evening's talk. So first of all, can I just get a hands up, bit of audience participation for who has heard of Babylon before this evening? That's pretty good.
Are you advertising on the tube?
The money's working. The money's working, huh? And GP at hand? Good. Still hands. That's good. Okay, so most of you then, by the sounds of things, are familiar with, broadly speaking, what it is that Babylon does. But for those of you that aren't, Babylon is much like Vishal was saying about Ada. Babylon has similarities in that it is a chatbot-style interface that provides you with triage functionality and diagnosis as well, or probabilistic diagnosis. We are, with respect to Sarah's talk earlier, we are the AI behind the 111 online pilot in North London. So that's NHS Online 111 powered by Babylon, to give it its full wordy title. We are also a clinical services company, so we provide video consultations to, well, our member base at the moment is 500,000 people in the UK and just over 500,000 people in Rwanda. It'd be interesting to pick people's brains later on what they think the differences are between good value for money healthcare in the UK and good value for money healthcare in Rwanda too. So it's also worth saying that we're on the NHS Digital Apps Library. Thank you to Sarah for a mention there and to the help of all of her team in supporting us through that process. In terms of value, this is I always feel slightly awkward as a British person doing the kind of the sales spiel at the beginning. But when you walk through the door at Babylon, there's a big sign saying that our mission is to put an accessible and affordable healthcare system into the hands of everyone on the planet. And that does genuinely drive everything that we do, and that's what value means to us. So is it accessible? Is it affordable? Does it make people better? And I suppose there are ways in terms of putting cold, hard facts and figures to that, that we're now able to do that we haven't been able to do so far, and that I think very few people working in the direct-to-consumer healthcare space have been able to. So one of those is, what sort of money does actually save the healthcare system? And so you quite rightly mentioned that there's a whole load of strange silos across the NHS in the UK that mean that people don't adequately account for the total cost of your interaction. It's fine to go to A&E, it's fine to go see a GP, but actually what's the delta that you're talking about for using healthcare resources inappropriately or duplicatively? We can say that on average, for every triage that somebody has with our 111 online system, we save the NHS £10. That information has been pretty kind of broadly absorbed into the NHS by now. And the other thing that we're starting to look at, there's a bit more of a leak for this evening, is that we're starting to see with our GP at hand service, where we provide video consultations to patients 24/7, 365 days a year, typically within 2 hours as a standard GP contract, rather than the 2 weeks a lot of people will be accustomed to in London. And physical consultations, same day or next day, worth pointing out, because not all things are treatable with a technological solution. We're starting to see quite a significant reduction in people's usage of A&E, just because you don't need to go to A&E if you can find out what's wrong with you via a video consultation with your doctor. So I suppose those are some lead and some anecdotes into what I hope will be a fuller discussion of value in a second. Thanks.
Yeah, thanks. And I heard Gil's definition in discussion, trying to conceptualize a little bit. What is it we mean by value? Is it the Porter-like ratio of patient outcomes to cost over the clinical care pathway? Or is it what you get from individual subjective stakeholders across the system? And how you define it is really material, because companies do need to make choices, investors do need to prioritize, startups do need to make decisions, choose markets, and so on. Are there other thoughts from the panel about what the largest sources of largest opportunities for value are, and how do you identify this? How do you make that claim? Karelee, you talked about quality, obviously from your experience, and some waste of cost, which Tom also addressed to. Do you have further thoughts on this?
Yeah, so I sit on BCG Digital leadership team, and so we look across healthcare, consumer goods, financial services, you name it, industries. There's not as much debate in those industries about where's the value of this stuff. Most organizations are saying, actually, technology is disrupting the way that most industries work. And there's no reason why healthcare should be any different. It's just slower and it's more complicated and stuff. Where's the value? I think it's good to talk about sort of academically, but practically, I think it's better to think about, where are the things where you can actually move the needle today, right? Where can you drive efficiency in the system? And if you're a provider that's, better outcomes for lower cost, a la Porter, I think. Where can you, and if you're a med tech or a pharma company, it's about, even simple technologies applied to your day-to-day operations. So, and we see by the, proper application of technology in other industries, 5, 6, 10, 20, 30% improvements in margins. So I think it depends on where you are. But I mean, if you say an example, it's better to start with something, I think, that works and you can get on with than it is to wait for the sort of perfect answer of where all the things come from. U.S. healthcare, I would argue, is further ahead in use of analytics, a lot further behind on a lot of measures, but on the use of analytics, we accidentally, through our analytics team, sort of came across a good use case around medical cost management for a very large payer organization. By using the existing data that they had, not changing the world's issues, but using the data that they had and understanding the pathways much better for one area of their care, we saved them $1 billion. So to me...
Who is we, Karelee?
We, BCG.
Yes.
We, the team, with the client, right? But I would argue that, and $1 billion's like, actually, I was like, really? Come on, guys. You've like inflated this. This is like whatever. But it's really genuinely using existing data to understand patterns of practice. That's one. If you're in biopharma, across the value chain, there's quite some opportunities to do things differently, right? So take the supply chain topics. You're closer to the supply chain. Take the supply chain topics. Take, what H&M and what IKEA and what Zara are doing. Why is that any different for what you do in biopharma? Yes, there's regulation, and yes, there's, some different processes, but using data to optimize what you have in and how you make the thing and how it goes out, for those companies in other industries, it saves them a few points of margin. Why does it not save margin in pharma? If I think about what pharma spends on commercial, right? Hundreds of millions of dollars on sending reps around. Well, how dumb is that, right? Sorry if there's any pharma people. But how dumb is that in a world where you're in omni-channel, right? So there is a human interaction that's really important, just like there is a human interaction in most industries. But there's a lot more data-driven, multi-channel interactions that people are tolerant of, and we just don't do that. And I mean, if you think about product innovation, we had one client that we can talk about a little bit more. They did a launch which had a thought process around improving the pattern of practice for healthcare. So they had a really undifferentiated product, which is about controlling nausea post-chemotherapy, okay? So they're basically not that different clinically from another drug that was on the market. So they were kind of staring at it going, how are we going to launch this? So they basically said, well, how would I actually put this into practice in a way that would change the way that patients use it? So they took the information booklet that was like this long, and it was really hard for anybody to understand, and they digitized that. They thought about the user experience. They implemented something where the nurses and the patients could communicate more about the application of the drug. They looked at ways of reducing the amount of time, or the need for a patient to come back in to be talked to post having the drug, and to make sure that something's going on. That drug launch was worth $1 billion to that company. Now, we don't know what it would have been otherwise. Might have been great, but likely not. And what the value is it was actually in reducing the cost to the system, and it was also in improving the efficiency of that pattern and making it more accessible to people. And I would just argue that, we need to think about, yes, what drives value, but also what can we get on with today with the technology and the data that we have today, and learn from that, because, trying to solve world peace, takes a bunch of steps, I think. And that's sort of, I think, the chicken and egg thing that we're in a little bit with healthcare.
Peter, Gil, and Tom, in your environment, how do you practically resolve this issue of what's the largest source of value, and do you have thoughts on this?
The way I think about it is there's fundamentally, for digital health, two types of areas that I would go after in terms of value. One is around what does the data tell you, and that can be looking at a disease state, cross-pathway, at a complex data set to enable better decision-making, as Karelee is saying. And I think that's one of the more complicated ones, because it is really about recognizing the total value, the total outcome improvement, the total cost improvement. But it's certainly where the biggest data set is, where the biggest opportunities are, and I think it's the most interesting area, in fact. The second one is maybe the more pragmatic, tangible one, and where the quick wins can be, but even some bigger wins. And I think about it as the ones that are inside the hospital walls, and they are the digitally enabled solutions. They're actually not digital, driving digital for the sake of digital and becoming more IT capable and being paperless. It's actually about efficiency, and it's about cost reduction, it's about income improvement, and it's about just doing what the hospital needs to do inside the hospital walls better, which is treat patients. And some of that can be digitally enabled. So I think value can be, for digital health, either about doing the day-to-day better, or making decisions that drive the strategy or the activity better. And that's how I think about it, really.
Can you help us understand maybe a bit more explicitly what opportunity is?
So if I take an example of something I'm working on at the moment, we're looking in Boston Scientific at one disease state for a digital health pilot that I'm leading around heart failure and the heart failure pathway. And heart failure is a very complex disease state because it involves a lot of comorbidities, and it tends to be a lot more in an elderly population. And it tends to be treated right across a pathway, a continuum of care, from primary care into the acute hospital setting, and then back to community settings, and then a lot of follow-up and readmission. And readmission can be a massive cost burden to the system, and result often in inappropriate admissions down the wrong channels, which can result in outcome reduction. So you can see where there's a lot of value pool for just getting heart failure right and managing that care pathway more effectively. So we've got a digital capability that we're using. I call it a digital health solution, but I veer away a little bit from saying that the solution is digital. The solution is actually doing things differently in the heart failure pathway by having a fully informed understanding of the pathway, first of all. So it's analytics and data understanding, measuring every touch point for heart failure patients across the pathway before and after what we're doing in the pilot, so that understanding the data and the impact. Engaging patients better. There's a big digital piece there by automating some of that activity of patient engagement and education that digital can help us do in a way that nurses and all the workload that is on them can't do as well or as much of. And thirdly, just managing that workload in the hospital, which is huge. You know, the heart failure team in the hospital we're working with in the Northwest is seeing about 60% of the patients that they need to see. So what we developed was an iPad-based system, which behind it is an algorithm that is identifying where the heart failure patients are in the hospital, so that they choose the best route to get to them as quickly as possible. Who are the highest risk ones, both before speaking to them and iterating that after speaking to them, and as a result, giving a recommendation on who do you need more touch points with over the care afterwards, and who do you need less touch points with. So as a result, you can see a lot of things that can be digitally enabled, but what they're actually doing is reducing the burden of activity, increasing the efficiency of the team, increasing the patient engagement in their own condition, understanding the condition better and what are the things that really move the needle, and as a result, improving the outcome and reducing readmissions, costs, improving outcome, we hope. But it's a pilot in progress, but it is showing very positive signs now into sort of month 6. So yeah.
Just wondering if I could
Please,
jump
Tom.
back in on that as well. So I really related to when you're talking about a digitally enabled solution rather than a digital solution, or I heard people talking about digitizing things a bit earlier, and I thought, no, we don't want to digitize current processes. This is wrong. Sometimes you want to digitize current processes, but the moment we start thinking about digital solutions as digitizing, we've missed a trick. So we talk about Babylon as being an accidental healthcare company. And if you go back to this accessible and affordable healthcare on the hands of everybody, in the hands of everybody on the planet shtick, then really that is about how do you focus around making things more accessible. Okay, that's how we started down the road of video consultations. Then you start to think, how do we make them more affordable? You think doctors are expensive, about 2/3 to 3/4 of the total cost of delivering medicine, depending on where you are. So we're not going to get anywhere near completing our mission if we don't do something with that, hence artificial intelligence. And that's what we've got 300 people kind of beavering away in London doing. But I think it's really, really important to look at the problem quite holistically and then to go, do you know what, this is the sort of the set of solutions we propose to these problems, not this is how we make a slightly incrementally more efficient version of what we currently have.
Right. Peter, do you want to speak?
Yeah, so I'll come back a little bit to the comment at the beginning, which was we do see very two different separate approaches here, and for me, we engage in these big projects. Actually, we have a project that's almost identical to the one you're describing for healthcare pathways, and these projects have enormous value and enormous potential, but they are phenomenally difficult to manage and to implement, and they involve coordinating across different departments. You have potentially people with existing IT systems in those departments that they own, they're very used to, and you're proposing something where actually you might be giving more value to one department while you're asking another department to do a bit more work, and so it might actually slow them down a bit. So these kind of big value propositions, they are often incredibly difficult to realize, and they require a very long horizon a lot of patience and very strong partnerships to bring them into reality. But if we think about the idea of trying to do what we can today with the systems that are there, perhaps an example I can give of what we've done at Siemens is there's when a heart failure patient has an MRI scan, that's a doctor has to sit down and draw around the heart, and that takes about 30 minutes. Might take someone up to an hour if it's a particularly complex case. That's not really the reason doctors got into the job that they did, right? They don't want to sit there drawing around these hearts. At Siemens, we've been working with machine learning since about 2005. We actually have over 30 products out there that have some kind of machine learning or AI in it already. And we have a product out there that allows AI to automatically segment and contour these hearts in a matter of seconds. And that frees up the doctor's time immensely to go and do other things that they wouldn't be able to do otherwise if they're sitting there drawing around hearts. And not only are you freeing up the doctor's time to do something else, they're happier because, as I say, that's not the reason they got into medicine. And so I think there are small pockets where you can apply technology and get really, really powerful results. These are somehow easier to engage with than these big projects that are cross-department and require really, really strong, long time horizons.
Yeah. Why this is hard, we've gotten tons of really inspiring examples of these great source of value you can achieve with digital health, and you've talked about the challenges, the partnerships, and really how to get there. What is your vision? And maybe I can start with Karelee. What is your vision of what makes it hard and how to overcome this?
You raised a good point, which is the value and the cost of, or the pain of doing the thing are often mismatched, right? So it is, it's finding the spaces where you actually can move the needle and you have the incentives aligned. But I would say outside of healthcare, large organizations struggle with all this kind of stuff quite regularly, right? They struggle with, they've got 100 different types of technologies or digital pilots or whatever happening throughout their organizations, and they have trouble scaling it, right? So, one technology in one place is fine, but it's actually hard to build industrial scale. Why? Because you don't have the capabilities in the organization. You don't have the kind of way of working of a more agile startup. You don't have the right ecosystem to build. And I would say if you take it to the UK context, and I do some work in the NHS, the skills and capabilities around technology, around clinical engagement, around change management are just, frankly not really there in most organizations. So what makes it hard is the change, right? Scaling the technology and, whatever. So find the business case, scale the technology, and then manage the change. And I would say 80% of the issue is the change. And it comes down to, the doctor who's driving the thing or the word clerk who's like putting the forms in, and they've always done it that way, right? They've always done it and their power is getting taken away if you measure how good he or she is. And frankly, that happens, across a lot of industries. I think we just have different power centers in healthcare. But I think being able to prove that you can do it in small steps really does help. And the organizations in telco and retail and oil and gas and energy that sort of have those lighthouses, so they have early stage things, not pilots that you throw away, but lighthouses that prove the concept and the ability to scale those, then they make progress. And I mean, what they also do is they have to really invest behind it, right? They have to find the way of the sort of intestinal fortitude, so to speak, to change the way that things work. And if you look at across industries where there's been more transformation, take media, for instance, those newspapers of the past, had they not transformed, they'd be dead, right? Healthcare, at some stage, we have to get to a place where you either realize that you're going to change or not, right? And in some ways, it's like the industries that have got to the edge where it's a do or die thing, they make more progress. Other industries where, it could happen, it could not happen. There's been a budget issue in the NHS for a long time. Maybe we'll change, maybe we won't. That's where there's not enough pressure on the system to actually make a difference. And I think it's the pressure and the capability, the combination of the two that we need to think about.
How do you think of overcoming the challenge to realize value? So what are best practices that you've observed that you think are useful maybe to hear from for the audience?
Yeah, so I mean, if I take it maybe from an external perspective, I think Karelee touched a lot on the internal items that are sort of needed to get an organization to change. That totally resonate with even a med tech company like mine has a lot of change management to do internally because we're not talking anymore about selling widgets. So we're not, things that you can touch and feel, that you can develop. We're talking about selling software or even just solutions, right? So there's been an enormous amount of change management, but I won't go into that. I think on the external side, certainly agree with the point around change management. So enabling adoption is fundamentally about change management, and having the ability to try, test, feel, iterate, gets over a lot of the hurdles that the change management challenge presents. So I
Gil,
think
I'm going to interrupt you for 1 second. I apologize, because you're really leading into one conversation. Failing fast is hard
Yeah.
in healthcare.
yes.
And
It's hard in a lot of places.
Peter, you were telling me about this.
So I think one of the things that's very, very difficult in healthcare, it's very difficult to test your business hypothesis. For example, if you want to run a test to change a process in a hospital, you really have to do that, right? You have to go in there and you have to see how people react. It's not like, say, if we look at Airbnb, where they made a website, they put some rooms on there, and they were able to get an understanding of what the appetite was for their product, and then extrapolate some value. You can fail very quickly in lots of different industries, but it's very difficult to actually run pilot studies when you're engaging with hospitals, for example.
I think it depends where you are, though, right? Because, so if you're in clinical practice and clinical process, yes. But if you're in administrative process, so the stuff that's around the clinical practice, I don't think it's as hard.
No, I agree with that. I'm thinking more if we're making clinical products is where I'm coming from.
Definitely.
Yeah.
Not the Advantix type of hospital management and
Yeah.
state of that.
But we have a U.S. hospital example where, so the clinical practice definitely, but okay, so one of the issues that they have is like people coming in for repeat to be seen for regular testing because they're on a certain medication. So they looked at it and sort of said, well, okay, well, what happens if I send them a reminder in the post? Okay, I get this kind of response. What happens if I send them a text message? I get this response. What happens if I send them an Uber car and get their little butts over into the hospital, right? And actually, it's that kind of thing that can actually, they're not changing the way they do heart surgery, for sure, but they're changing the way they do follow-up, they do engage with patients, and that kind of thing. And so I think it really depends where you are, and quite often we go to the hardest thing, which is at the heart of medicine, and we forget that there's a lot of stuff about healthcare that's really quite supply chain and process oriented. It's getting people in the right place, getting people educated, getting the right people to see the right people, and getting the supplies working. And I would say start with the stuff that's not so close.
Yeah,
And
patient facing
where
is
if you fail,
difficult.
you won't hurt somebody, because that would be not good, right?
Yeah.
But where you can, get people used to it, get people engaging in a different way.
We're talking about barriers to entry, barriers to implementation. Tom, I want you to address these questions. How do you manage to achieve the partnership with NHS? And there's also the previous question that talks about there's criticisms around the implications of your partnerships in terms of A&E, secondary care referrals.
So I think actually I agree a lot with what Karelee was saying about just getting something up and going. So for us, we started off, okay, as I say, in the video consultation space, what have you got to do to make healthcare more accessible? Frankly, all you need is a GP and Skype, and then you're basically there. You need GP, you need Skype, and you need somebody that wants to see a GP. And so that gets the ball rolling. And then you start to look at, okay, well, what are the potential audiences for this? How can we start to develop a bit of scale? For us, that was let's go to businesses and work this in as an employee benefit. It's not a massive step for the businesses to take. They can clearly see the value to their employees. And then again, you start to build up a bit of scale and you start to be able to say, hey, look, we're saving you X number of days off work because people use the service and they like the service. And then you start to say, all right, well, we've got that going. Now, we realise that private healthcare is 10% of the market in the UK. And if you want to be accessible and affordable, hands on everybody on the planet, all that good stuff, then you're going to have to deal with the other 90%. who are a lot harder to reach. So perhaps you can start working in, I don't know, anywhere where there's a will and an ability to innovate a bit. And primary care is actually totally right for that, because a lot of people talk about NHS GPs, and it's true that NHS GPs provide NHS care, but actually they're all private businesses. So all you need is one GP that's willing to give your software a go, that's willing to try out your way of working, and then you can start to build from there again. So we went back and forward on this, kind of scaling, and then just decided that with the launch of GP at Hand, which was the service that we initially launched in June of last year, but people really heard about in November, that we were going to go for a bit more of the value chain, that we were going to start working across the full spectrum of primary care that people expect, whether that's physical consultations or video consultations or home visits. We do home visits too for people that require them. The whole sort of the whole spectrum, and we probably won't stop there, to be honest with you. And we factor in AI along the way, as I say. But the idea of building fast, building quickly, getting to a minimum viable product, and then scaling to the next thing,
That's really useful. I'm going to ask you to answer the next question. Ask My GP, more A&E and secondary care referrals?
3 points on this. One, Ask My GP may well be providing a terrible service. It's delivered by Sensley, not Babylon, in the West Midlands. I think you're probably referring to either GP at Hand or NHS Online, which are both Babylon products. So, in terms of the leading to increased A&E attendances, haven't seen any evidence for that. As I alluded to at the beginning of the panel, we've actually very recently, as in over the last week, have been shown data by the NHS from their own systems that indicates that actually the rate of A&E attendance has gone down significantly for GP at Hand patients. Not at liberty to disclose the precise numbers around that. Hopefully they will soon. I don't want to kind of steal the thunder there, nor should I. In terms of excessive capitated payments, there's a lot of misinformation around about this. And for the scholarly amongst you, the document that you should be referring to is Annex D of the 2013 Financial Entitlements Directive of the GMS contract. Which is the kind of the key document that all GPs work with in the NHS. And this sets out the Cahill formula, which describes that if you have it weights the amount of money you receive based on your patient demographic. So for us, a 20-year-old man attracts an index multiplier of 1, and an 80-year-old woman attracts an index multiplier of about 6.6. So you get paid, I think, 6.73. You get paid 6.73 times the amount for an old female patient that you do for a younger patient. So yes, we have younger patients, and we are paid less for them because they take less healthcare to service.
That makes sense. Thank you. And the last question I want us to finish it on, and I think I'll ask Gil and Peter as representative of the medtech company about the tech giants getting into digital healthcare. How much of a barrier to entry from regulation, how much of a threat do you think of companies like Amazon in your respective companies? Peter, do you want to start?
Yeah, sure. Coming into these news areas, it is always very difficult, but they come and hire people, right? So the same people who have done it for other companies will be hired by Amazon or they'll partner. And actually, the way that we're seeing the ecosystem for healthcare evolving, it is much more about opening up and partnering. So actually, we're at Siemens, we are, for a very long time, we were relatively closed. We had our install base of scanners and imaging devices, and we didn't like to share access to those. We like to deploy our own software on those things. But it's really changing now. We are becoming much more open. We have a digital ecosystem platform that we're releasing, and it's about making those scanner bases accessible to all companies who want to come in and who can deliver some value. It's the technology is moving very quickly, and we have our roadmaps and we have our products that we're developing. But we also recognize that smaller companies or big companies coming into this space, they can also add value that we can benefit from as well. So it's certainly something to take very, very seriously. But I think as an incumbent who have been there for a very long time, we're relatively confident in our position, and we've definitely got our roadmaps for the future.
Gil, what do you think? Yeah, in terms of tech.
So I think if you're referring to things like Amazon, JP Morgan, and who was it? Sorry?
Roche.
Yeah, together forming a healthcare company that is addressing the U.S. healthcare cost. I'm not in the slightest bit worried about impact on medtech. If anything, I'd say good luck to them. I think it's a high time that healthcare costs in the U.S. found a way down. I'm not very confident in their ability to do it because I think the incentives are completely misaligned. But yeah, I'm all for.
Can I ask you to elaborate a little bit on this, the incentives being misaligned?
I just think that if the people that are the people looking after the system ultimately in the U.S. are insurance companies, and insurance companies are not incentivized at the moment to find a way to reduce the cost. So I think the U.S. system has got a lot of work to do before the costs go down. But so I'm all for innovative solutions like what Amazon and co are trying. When it comes to sort of the Googles and Amazons and others who are accessing data and trying to democratize data and do something with it, I think the answer is it depends. It depends how responsible they are, and it depends how well the regulation catches up. So I think Sarah Wilkinson touched very well on the fact that, yes, the NHS is a huge pool of data and is very aware of the information governance responsibilities it has and the need to put the frameworks in place. And by and large, they are in place, but they're also catching up all the time with technology that is getting ever more sophisticated at Moore's law of increase, right? So it's very tricky, I think, because the tech companies are working at a very fast pace due to the way that they do work. And I think there's a danger, and you saw it, I think, with the DeepMind, Royal Free controversy that took place, that those, you get a few more of those kind of situations, and people will not, as Vishal was saying, feel free to release their data, which is where the real change will start to come from. So I do want to see more of that happening, but I also want to see that the tech giants, take a responsible approach and work in partnership with the regulators and with the people that are the safeguards of the data, so that it's done in a responsible way and it ultimately benefits all.
Microsoft was in a long time ago with Health Vault and lost a ton of money. So these guys it's not a shoe-in that they understand really, really what's going on. What's cool, though, is it creates pressure, right? So that entry and that announcement makes a lot of CEOs think, what am I missing? And it also makes us think about applications from other industries. So you have a couple of new chief digital officers in biopharma that have come from those spaces because you can see that is a threat, right? And you start to see that that will create more, as I said before, that it will create more pressure and more incentive for people to look at doing things differently, and I think that would be helpful.
That's